Welcome to this pleasant evening. I'm Nakul Patil, Senior Product Manager. We at MQR, Inventia Division, for Fcm is our core brand and epitome of quality and success. MQR has helped more than 60 lakh Indian patients to rapidly correct iron deficiency anemia, and furthermore, we are taking a pledge for making India iron strong. Today, MQR team is honored to have esteemed speaker Dr. Vinay Kumar Bora and having expert panelists like Dr. Jignesh Diliwala, Dr. Ritu, Dr. Mahendra Soni, and Dr. Roma. We are thankful to all for giving us opportunity to host this scientific webinar and be a partner for this wonderful academic educational initiative. Today, Dr. Vinay is sharing his view on Fcm in management, in ID management. Now, may I take this opportunity to introduce today's speaker, Dr. Vinay Kumar, and expert panelist. Just sharing my screen.
Nakulji, Dr. Jignesh is also there, so you can introduce him.
Right. Is it visible?
Yes, it's visible. It's visible.
Yeah, right. Yeah, Dr. Vinay Kumar Bora, he did his MD in medicine, DM clinical hematology and hemato-oncology. He has taken a fellowship in leukemia as well as and bone marrow transplant from Canada. Currently, his designation is he is a consultant hematology and bone marrow transplant. He is currently working in CHL CBCC Cancer Center from Indore. He is a consult. He started his career as a consultant in hematology and bone marrow transplant at CHL. Oh, sorry. CHL CBCC Cancer Center, Indore from April 2016. He has successfully performed first haplodentical bone marrow transplant and first pediatric allogenic BMT. He has interest in to deliver patient education programs such as like radio as well as television talks on common hematological disorders. He has many research articles, research papers has published. Apart from this, just wanted to introduce today's panelist, Dr. Jignesh Diliwala. He is a practicing gynae at Ahmedabad since last 18 years. He is a president. He was a president AOGS in 2020-21. He is a past joint secretary in AICOG 2070 and a special interest for the Dr. Jignesh in high risk pregnancy as well as in fetal medicine. Another panelist, Dr. Ritu. She is a director, Integra Specialty Clinics at Nagpur. She is a consultant in charge Ops and Gynae in New Era Mother and Child Hospital, Nagpur. She did MBBS and MD in Ops and Gynae from Mahatma Gandhi Institute of Medical Science. She is a master trainer for the Emergency Obstetric Cares Program. And activity involved is like community activities, which includes adolescent sexual health education in schools, screening of women for gynecology cancers, and health awareness session for the public at various platforms. Then with us, Dr. Mahendra Soni is there. He has completed his MD in 1981 from BG Medical College, Ahmedabad, Gujarat. He is hosted SOGOG conference in 1994 as a chairperson. He was a president in 1995 and special interest in critical obstetrics and infertility. Then with us, Dr. Roma is there. Dr. Roma is a consultant of Ops and Gynae at the Nirmal Hospital, Kanjgar. Her special interest in high-risk pregnancy and gynecological surgeries. Currently, she holds the post of Joint Secretary of GOGS and Joint Secretary at IMA State WDW. She is a treasurer in Indian Menopause Society and as well as treasurer Foxy Web Zonal with UA. Welcome all delegates and welcome all today's experts and panelists. Just wanted to highlight one thing over here to all delegates. Surely means Definitely, our expert will address once session gets over. Means whatever the questions are there, whatever the doubts are there, you can just you can means have that in chat box. Yeah, once again, welcome Dr. Vinay Kumar, and over to you.
Right. Thank you. Thank you, Nakulji, for this kind introduction. And thank you, respected speakers, for respected panelists for being here. So over next, say 20 to 25 minutes, I would be briefly highlighting my experience of using Fcm in the treatment of iron deficiency, not only in pregnancy, but of course, we would be dealing with mainly use of Fcm in pregnancy. So I would be sharing my screen. Am I audible?
Yeah.
Audible.
Okay.
Visible.
Right. Yeah. So we all know that all over the world, may it be Western world or in the part of world where we live, anemia is quite common in females, simply because they bleed. They bleed during starting from menarche to menopause, and everywhere iron deficiency anemia is common in pregnancy. So in India, the prevalence, this is what National Family Health Survey says, the prevalence of anemia in pregnancy is around 52%, while in non-pregnant females, almost 60% of the females may be anemic at any point of time in their life. So anemia in pregnancy as well as anemia in non-pregnant females is defined in different ways. But to make it simple and not to make it complicated, we know that WHO defines anemia as hemoglobin of less than 11 gram% during any trimester of pregnancy. And by that, I think almost 80% of the females would be anemic starting from first trimester up to third trimester. The story doesn't end here, because even postpartum state, WHO says that hemoglobin less than 10 would constitute anemia. So as far as causes of anemia in pregnancy are concerned, because as a practicing hematologist, I get a lot of patients who are pregnant and who have anemia. But in my experience over last 7 to 8 years, I think most of the iron deficiency anemia in pregnancy would not come to me because they are managed by obstetricians. But still, out of total patients who are pregnant and anemic and who come to me to consult me for their anemia in pregnancy, almost 70% of the patients still have iron deficiency anemia. Remaining 30% would have different and probably rare causes of anemia in pregnancy that we will be discussing in brief as we move on during this presentation. So for a normal non-pregnant female, the total requirement of iron during before they achieve that menopause is around 1 milligram per day. This would remain constant during first trimester. But as we move on from second to third trimester, because there is now expansion of blood volume, there is expansion of the size of fetus goes on increasing, the iron requirement of fetus is tremendous. That is how the daily requirement of absorbable iron, I would say, would be around 8 milligram per day. This might appear very small, but because only 1 to 2% of oral iron is absorbed, we have to actually give more than 150 milligram of elemental iron, and then probably 2 to 3 milligram of iron is actually absorbed. So total requirement of iron in pregnancy is around 1200 milligram. So that comes to around 4.4 milligram per day. So we all know that, in fact, most of the respected panelists, they would know that consequences of iron deficiency anemia during pregnancy would be on mother as well as fetus. So because of anemia, we have reduced oxygen carrying capacity, which will lead to fatigue, weakness, palpitations, tachycardia. Patients might have nausea, weight loss because of hypoxemia. Central hypoxia is very rare, but it is said that maternal anemia would contribute to 18% of perinatal mortality and 20% of maternal mortality in this part of country where we live. During pregnancy, severe iron deficiency anemia, for that matter, severe anemia of any etiology, would increase the incidence of preterm delivery, eclampsia, preeclampsia, rarely intrauterine deaths. It is said that anemia actually reduces your immunity by multiple ways, and it can lead to intercurrent infections, antepartum hemorrhage, as well as congestive heart failure. In fetus, because of lowered oxygen supply, it would lead to low birth weight, prematurity, infections, congenital malformation. I'm not very sure, but neonatal anemia because of iron deficiency. Now, this is not seen during in neonatal period, but once that child is 3 month, 4 month old, then probably if the maternal iron stores were not sufficient, infant would develop anemia. So diagnosis of iron deficiency anemia actually does not require a lot of sophisticated tests. Simple history, physical examination, which would show platinikia, koilonikia, a careful interpretation of CBC, which would show anemia lower than expected RBC count, lower MCV, lower MCH, and higher RDW. In fact, once we have lower than normal or lower than expected hemoglobin with lower MCV, mean corpuscular volume, and higher RDW, it is virtually diagnostic of iron deficiency anemia. We can simply do ferritin if ferritin is less than 30. In pregnancy, the cutoff is 50. But if it is less than 30, patient can be labeled as having iron deficiency anemia. On the other hand, it is very important to differentiate iron deficiency anemia from thalassemia minor, because that is the first opportunity most of the obstetricians would have to diagnose thalassemia minor. In patients with thalassemia minor, they would present again with low hemoglobin, lower than normal MCV, so microcytic RBC, but here RDW would be normal. So higher RDW, iron deficiency anemia, normal RDW, thalassemia minor. Apart from that, some people would go ahead with iron studies like iron TIBC, transferrin saturation. But having said that, just doing serum iron TIBC without serum ferritin would not give us a reliable indicator of iron deficiency. Serum ferritin cutoff is 30, but in thalassemia minor, the cutoff is 50. Any lady who has thalassemia minor, who is pregnant and she has anemia, if serum ferritin is done, if it is less than 50, it makes sense to replace iron. For non-thalasemic patient, the cutoff is 30. Bone marrow examination is not required for diagnosis of iron deficiency. Peripheral smear is very important. We might see microcytic hypochromic RBC and teardrop cells and etc. But low hemoglobin, low MCV, and higher RDW, along with low ferritin, is virtually diagnostic of iron deficiency anemia. So I think everyone knows that once patient is diagnosed with iron deficiency anemia, the first knee-jerk reaction would be starting oral iron. I think a good number of patients, especially in pregnancy, because of the effect of progesterone, they would have a lot of GERD. So some patients actually stop taking oral iron, and that is how they become non-compliant, and then the iron deficiency is not corrected. For severe anemias, when hemoglobin is less than 7, we are inclined towards hospitalizing them and giving blood transfusion, because in first trimester, most of the ladies who have iron deficiency would neither receive IV iron, and oral iron is not given, I think, because of the risk of nausea, because of the problems of nausea and vomiting. So when do we switch to parenteral iron therapy? And that is the topic of the day, because I think most of the people would not be inclined to starting IV iron in first, upfront. So those patients who do not tolerate oral iron because of either say constipation, GERD, or diarrhea, and those patients who do not absorb oral iron because of so many reasons. So failure of oral iron therapy, either because of non-compliance or because of resistance, would constitute class 1 indication of giving parenteral iron therapy. There are rare patients who have undergone surgeries prior to pregnancy, or because they have malabsorption. Celiac disease is quite common. So these patients would not absorb oral iron, and these patients would receive IV iron. Whenever rapid rectification of anemia, or more than that, rapid repletion of iron stores is desired or expected, we can depend on parenteral iron therapy, because in one sitting we can go up to 500 to 1000 milligram of Fcm, and to replace same dose, it would probably take more than 3 to 4 months if oral iron therapy is used. There are a few contraindications of using parenteral iron therapy. First is, of course, gestation period, which is less than 12 weeks. I think we don't have studies to show that drug is not teratogenic or it will not harm the fetus. And very important, lack of facilities to resuscitate in unfortunate event where patient would have anaphylactic reaction. Although anaphylaxis is rare with FCM, anaphylaxis may be still common with iron sucrose and older iron preparation. But with FCM, if it is properly used, we do see allergies, but anaphylaxis may not be that common. In those patients who have history of anaphylaxis or reaction, past reaction to parenteral iron, and in those patients who have thalassemia major, sickle cell disease, these patients do become pregnant when they have this iron overload state. We would not give them parenteral iron therapy. So if we look back into the history, there were various drugs which got approval during different time points in the history. Ferric iron sucrose was used in 2000s, and then came carboxymaltose in 2012, 2013, and now we have iron isomaltoside. Probably it is available in India for last 2 to 3 years, supposedly better than carboxymaltose. So this actually iron is highly labile. If iron is directly given IV without any carbohydrate moiety, it would lead to generation of a lot of free radicals, and that would lead to reaction. That is why the structure of iron is prepared in such a way that iron is actually covered in carbohydrate moiety. The sucrose is carbohydrate moiety. Then carboxymaltose again is a carbohydrate moiety, and that is how the safer preparations have evolved. And now we can say that we have safer iron preparations, and these preparations can actually allow administration of larger doses of IV iron, so that patient doesn't need to visit daycare facilities or hospital to get IV iron every 3 to 4 days. So if we briefly compare, we don't use iron dextran anymore. Iron sucrose is still commonly used, but if iron sucrose is compared with carboxymaltose, the half-life of carboxymaltose is half-life of carboxymaltose is almost 16 hours. The pH is near neutral. Osmolality is isotonic. This is very important because this is how reactions are avoided. Antigenicity is very low. And I think iron sucrose, we cannot give more than 200 milligram in one sitting, and test dose is needed. Here they've mentioned that test dose is not needed, but I think for iron sucrose, test dose is needed for each and every patient. For carboxymaltose, test dose is not needed. Iron sucrose would be given over 2 to 3 hours. Carboxymaltose can be injected over 15 to 20 minutes. Carboxymaltose, the maximum dose which can be given is 20 mg per kg. It is to be capped at 1000 milligram. For still newer preparation like isomaltoside, we can go up to 1500 milligram. But for iron sucrose, I think 200 milligram is the maximum dose. So I think these details are not very important. But in first generation, we had iron dextran. In second generation, we have iron sucrose, still used at some places. But now this is being replaced with ferric carboxymaltose, simply because it is safe, simply because patient doesn't need to visit daycare or hospitals repeatedly. And in one sitting, we can give up to 750 to 1000 milligram in second or third trimester of pregnancy. So with iron sucrose, as we've discussed, it can be administered in low doses because it incorporates very highly labile iron, which can lead to a lot of reactions, including anaphylactic reaction, and multiple clinical visits are required because 200 milligram or probably 300 milligram is the capping dose every visit. While in carboxymaltose, it is approved for the treatment of anemia in so many indications, and we can go up to 1000 milligram in one sitting. Isomaltoside, because it leads to lower incidence of hypophosphatemia. Some people are giving up to 2000 milligrams a day, iron isomaltoside. So what are the advantages? This we have seen that it is safe even at higher doses. 1000 milligram can be given in single sitting, 20 to 25 minute infusion. Fewer clinical visits are required, and low because it has neutral pH and the osmolality is similar to plasma. It leads to lower rate of injection site reactions. No test dose is needed, and I think most of the advantages we have discussed. So if we try to summarize FCM in few sentences, it is usually not associated with hypersensitivity. It can be administered in much higher doses because the structure is very much similar to ferritin. Ferritin is a molecule which is stored, it's iron store molecule which is stored in reticuloendothelial cells. So structure is similar to ferritin. That is how this molecule can be easily stored in reticuloendothelial cells, and from there the iron would be released to marrow for hematopoiesis. It has got very low immunogenic potential. test dose is not needed. And on the top of that, because we are today talking about use of FCM in second and third trimester of pregnancy, there are studies from Western world, there are good number of studies from Israel and good number of studies from India, which have looked at safety as well as efficacy, and they have not shown any adverse effect on fetus as well when this was used in second and third trimester of pregnancy. So simply, if patient is between say 35 to 70 kilograms, and if weight hemoglobin is less than 10, the dose can be, we can go up to 1500 milligram. Usually 2000 milligram is not recommended, because in my personal experience, when I tried to cross that barrier of 1000 milligram and tried giving 1500 milligram, good number of patients actually had severe reactions. They had muscle cramps. So one of the patients had actually had seizure, and when we looked into literature, we found that higher doses would lead to hypophosphatemia. That is one. And we are inclined towards giving higher doses over a prolonged period of time, but that's a wrong practice, because when we cross that time limit of 35 to 40 minutes, the iron preparations are very labile. They start becoming unstable. That leads to a lot of chemical changes in the solution, and that leads to reaction. That is why usually up to 1000 milligram is recommended in one sitting, more so in pregnant females, and it should be given in less than 30 minutes. The dilution should not be more. We would be coming to that in next slide also. There are a few important clinical and practical points which we should remember when we give FCM in pregnant, or for that matter non-pregnant patients. Dilution, just a minute. The dilution of ferric carboxymaltose in high volumes of saline beyond recommended volume actually are not indicated. They are not required, because concentration of FCM less than 2 milligram per ml is not permissible. Because if we go, with higher volumes of normal saline, if we try to dilute this dose beyond this less than 2 milligram per ml, it would definitely lead to hypophosphatemia. And simply because when the volume is more, it takes more time to infuse, and that leads to a lot of adverse reactions. So longer duration of infusions are not advisable. We should try to finish them between 15 to 30 minutes. Longer duration of administration and excess dilution may lead to destabilization of this iron complex, and that causes hypophosphatemia. Monitoring, very important. I think we should have a consent ready whenever we give in at our center, because we give a lot of IV iron for non-pregnant patients, and we have seen reactions ranging from mild up to anaphylaxis and seizures, convulsions. We made it a protocol that we would be taking informed consent when we give FCM. This should be administered in daycare, at least in daycare, and it should be given by a nursing staff who is trained to evaluate and manage side effects, which can be as simple as minor allergic reaction or as severe as anaphylactic reactions. And resuscitation facilities should be available. In our center, once infusion is over, we ask patient to stay in daycare or in ward for at least 60 minutes. If patients are fine, then we let them go home, because there are incidences where patients have gone home and on the way they had severe reactions. So majority of the Indian pregnant females who have anemia, iron deficiency anemia, we would probably give them around 1000 milligram in one sitting, and the same dose can be repeated 1 to 2 weeks apart. Before we give them IV iron, we should be sure that this is iron deficiency only and there is no other cause of anemia. We can have their peripheral smear and simply ferritin. Iron TIBC, transferrin saturation, doesn't help us to diagnose iron deficiency, and 750 milligram into 2 injections or maybe 1500 milligram can be given. This would vary depending on the obstetrician preference and the hemoglobin value of the patient. So again, same dose. If the hemoglobin is less than 10, we can go up to 1500 milligram. This can be 750 or 1000 and then 500. This chart is very important, because if we are using 1500 milligram, the dilution should be in 250 milliliters of normal saline. If we are using something like 750 or 500 milligram, dilution can be as low as the volume of the normal saline used as diluent can be as low as 100 mLs. And the duration should be around 15 to 30 minutes, not less than 15 minutes and not more than 30 minutes. So there are many papers, and I think you all know this. A good number of papers are from Western world, and most of the papers, in fact, all of the papers have looked at efficacy and then safety of ferric carboxymaltose, where they have shown that that group which received IV iron did better than that group which actually received standard oral iron. And again, coming to the conclusions of most of the studies, this ferric carboxymaltose can be given as 2 infusions of 750 milligram, can be given 1 to 2 weeks apart, and it should be considered as a treatment option of iron deficiency anemia patients who do not have response to oral iron or who are nearing their term and do not want to take oral iron because of a lot of side effects. And I think definitely FCM is better than sucrose in many aspects, lesser reactions and fewer hospital visits. And once we give this, we are sure that if patient has iron deficiency anemia, hemoglobin is going to increase. Again, safety and efficacy, same study where they have shown that it is well tolerated and it can be given as a single dose up to 1000 milligram. Number of studies they have mentioned, number of patients they have mentioned, and the maximum rise of hemoglobin was documented by up to 5 gram% over 1 month for those patients who had severe anemia and who received FCM. The ferritin increased by variable values from up to, from ranging from 100 to 500. I think this study again looked at safety, and this is from one of the journals of blood medicine, where they looked at safety and efficacy of carboxymaltose in the management of iron deficiency anemia, which showed that for those patients who had mild anemia, in HB increase was by mean of 2 grams, while those patients who had severe anemia, obviously once they receive iron, their hemoglobin would increase by more than 334 gram%. So this study was from India, which looked at more than 1,000 patients who were pregnant and who received ferric carboxymaltose. Again, same thing for patients who had mild anemia, in HB increased by 2 gram%. For patients who had severe anemia, in HB increased by mean of around 4 gram%. We actually don't look into rise in ferritin because we know that once we give carboxymaltose, ferritin is going to increase. So I think these are the parameters where they looked at vital parameters like blood pressure, heart rate, and it was found to be, because none of the patients actually displayed any signs or symptoms of acute hypersensitivity reaction or distress. So neonatal outcomes were better because when those neonates whose mother had received carboxymaltose when their gestational when their weights and Apgar scores were compared, they were better, and there were no adverse effects in terms of perinatal and neonatal outcomes in those women who had received FCM during pregnancy. So I think even in postnatal period, those patients who have postpartum hemorrhage and those patients who had iron deficiency which was not corrected to the extent in antenatal period can receive iron carboxymaltose. The recommendations are same, probably 750 to 1000 milligram. I think with this we are coming to last few slides where blood transfusion was compared with parenteral iron. We all know that when patient has severe anemia, when patients are symptomatic, when patient has severe iron deficiency anemia in first trimester, blood transfusions are better. Patients who are almost near term, severely anemic, I think blood transfusions are better. But apart from these two indications, most of the patients during their second and third trimester proven iron deficiency anemia, I think FCM would be better as compared to FCM would be better than blood transfusion. So I think this one figure shows the dose which is to be given, the dilution, duration, 3Ds are very important. Dose, we all know that we would not be crossing 1000 milligram, but dilution is very important. We should not overtly dilute it, and the duration should not be more than 30 to 35 minutes, because otherwise with more dilution and more duration, we are going to face side effects. So ferric carboxymaltose is ideal iron preparation in today's world. I think iron sucrose would be out. But of course, it is cheap, but it leads to a lot of adverse reactions, and adverse reactions are lesser with FCM. It doesn't need test dose. The dose are calculated based on body weight and hemoglobin value. Most of the Indian pregnant females are between 35 to 70 kilograms and hemoglobin is less than 10, they would end up getting something like 750 or 1000 milligram in one sitting. We all know that once it is given, we would expect significant increase in hemoglobin and blood indices as well as in ferritin. And Fcm 750, which I think is available with obstetric divisions. We don't use Fcm 750 a lot in our oncology patients. It offers flexibility for doctors to choose from the various iron preparations which are available for the treatment of iron deficiency anemia. With this, I would end my talk. Thank you so much.
Yeah, doctor, it was a wonderful session. If any doubts, means any interactions, if any questions, any panel or panelist, they can ask, please.
Dr. Roma has put up a question, I think she's asked it.
Yes, Roma.
Yeah, Dr. Vinay.
Yes,
FCM means ferric carboxymaltose can be used in puberty menorrhagia in patient with puberty menorrhagia.
Right, ma'am. It can be used, but there are two aspects. One is medical and second is legal. So even today, if we look into recommendations of correcting iron deficiency anemia, the upfront would be oral iron. If we document that patient is not responding to oral iron, or if patient is intolerant, then of course I would prefer FCM if it is proven iron deficiency, whatever is the etiology. May it be puberty menorrhagia leading to iron deficiency and low anemia.
Okay, thank you.
I just have a comment. I mean, comparing the cost of iron sucrose, and when you say it's more cost effective, but I don't think it turns out to be more cost effective if you see the cumulative visits that the patient has to do for sucrose. Every alternate day the patient comes, plus the visits, the consumables used. And I think everybody's pressed for time nowadays. So most of the patients want a quick fix. So I think FCM works much better as far as.
And I mean, to give 1000 milligram, they would be coming 5 times, right? 200 milligram per visit 5 times. So coming every alternate day and staying there for 2-3 hours, daycare charges and getting that IV line fixed. So that adds up. Yes, and the risk of anaphylaxis remains. So I don't know, ma'am, but how frequently do you see severe reactions in your pregnant patients? Because it's very important. Once we tell them in busy practice, it really is not possible to tell each and every side effect of IV iron. And once in a while it happens that we tell patients कि आप IV iron ले लो, and they have severe reaction. So
I have been using FCM for the past, I think, since it was launched. And initially when it was launched, I was in medical college and we did give, and that patient did have an anaphylaxis. I don't remember the brand. And then it was stopped as a hospital policy, department policy, not to be given. But then when I came into practice now for the past 12 years, I have been using it. I have seen, I would say I can actually count 2 or 3 patients, but most of them have come, 2 have come back after, like they've gone home and come back in an hour or so with, vomiting and giddiness.
Muscle cramps.
And muscle cramps, yes. Those who have received a high dose, they received a high dose from somewhere else and then they came to me that having severe muscle cramps. So, but severe reactions, touch wood, till now, I have yet to see in my daycare at least.
I would like to add one point myself, Jignesh Deliwala.
Yes,
actually, I come across one of the interesting article that is anemia in pregnancy in I think American College of Obstetrics and Gynecology. That they have mentioned that the anemia is one of the major cause of non-communicable diseases of that is fetal origin of adult onset, because during pregnancy, if mother is anemic, then and especially during second half of pregnancy, or I would say after 28 weeks of pregnancy, if the maternal iron stores are low, and if the baby they have studied so many patients also that the because of decreased iron stores and the anemic baby during first 3 months of their neonatal life, they can cause a very severe cognitive dysfunction also in the baby, and that would also, if the severity is low, that would also goes to the adult onset of fetal origin disease. So I think in my practice, I'm going means regularly do a serum ferritin level at around 28 weeks. If the ferritin levels are below 30, then I would definitely advise her for a single dose of iron, that is FCM, to replenish the stores, and that would benefit the baby in later life, that is early neonatal period. So I would definitely use FCM to replenish the iron stores that you have already mentioned in your indication of the FCM, Dr. Vinay,
Right,
that replenish the iron stores
Yes.
for mother. But I would say the store of iron store of mother will definitely indirectly benefit the baby
Fetus.
for
Yes.
their future adult life also. So I think this is a very important point I come across in my practice. So I routinely do a serum ferritin level at 28 weeks, even if the hemoglobin is around 10 or 11. Then I think we some generally in our busy practice, we generally see hemoglobin level 10, 11. That is okay, but not. I think we should go for serum ferritin level, and if it is low, then we should go for FCM. And second point that as Madam Ritu says that she had not any severe transfusion reaction or because of iron FCM, but I come across one of the patient have severe anaphylactic reaction with iron sucrose, because that patient has advised at my clinic for FCM, and she went to a general practitioner and he had given iron sucrose, and that patient had a severe dyspnea and breathlessness, and literally she was admitted in ICU for at least 1 week because of a single dose of iron sucrose. So I think in our practice, I would definitely switch over to FCM if but I think that patient was not pregnant, but in pregnancy, we should not take any risk for iron sucrose. Yeah. Thank you. Thank you so much.
So I think, sir, in most of the metro cities, tier 1, tier 2 cities, most of the obstetricians might have switched from sucrose to carboxymaltose, given the safety and better clinical profile.
Yes, yes.
Yes.
And I think I would ask also Dr. Vinay that we should always advise HB electrophoresis to each and every pregnant patient also, because sometimes hemoglobin is low and we start iron preparation, oral iron preparation also to the thalassaemic minor mother also. So I think to prevent, and also it is also a screening of the mother for thalassemia minor, so we can
prevent the birth of
find
thalassemia.
Thalassemia major also. Because
now, sir, there are two things here. First, it is a sort of misconception that we should not give oral or IV iron to thalassemia minor. Good number, even you would agree that in your practice, good number of females who have thalassemia minor and who are into their second and third trimester, they still have iron deficiency.
Yes.
Iron deficiency is so common. So that is why even if we start them oral iron, it is not going to make a difference. And number two, our intestines are so intelligent that if ferritin is adequate in the body, that happens with thalassemia major patients. When their bodies are loaded with iron, whatever iron they take, it is not absorbed. It is simply excreted in the stools. But second point is very important, because if we can, diagnose thalassemia minor in first trimester of pregnancy, definitely we will be able to prevent birth of thalassemic children. And simple in OPD office practice, we can just have a look at CBC. We can see whether hemoglobin is low or not, and forget whether hemoglobin is low or not. If MCV is low MCV and normal RDW, low MCV, normal RDW, it has to be thalassemia minor. Low MCV, higher than normal RDW, iron deficiency. But yes, these are very gross screening tools in OPD practice, but they have to be followed by
Yes. And one thing I would like to ask question that some of the reports also says that the patient is having alpha thalassemia trait, and
Right.
I think correction of anemia is required, and repeat the test after correction of anemia. Is there any importance of that report?
Yes. Now, alpha thalassemia cannot be diagnosed on HB electrophoresis. On HB electrophoresis, we can see beta thalassemia, we can see sickle cell disease, HBE, HBD, so many variants. But alpha thalassemia cannot be diagnosed on HB electrophoresis. The only clue they have is lower than normal HbA2. So there, even if we correct their iron deficiency, it is not going to, lead us anywhere. If we are suspecting alpha thalassemia, because alpha thalassemia is not very common in India, it is common in some parts of India, especially Jharkhand, Chhattisgarh, where we have a lot of tribal population, there alpha thalassemia is common. So for diagnosis of alpha thalassemia, if we see those inclusion bodies on smear, we directly do genotyping. So HB electrophoresis and other simple tests would not lead to the diagnosis of alpha thalassemia. But if patient has severe iron deficiency, beta thalassemia minor would be missed, because severe iron deficiency would lead to low hemoglobin, and low hemoglobin would automatically reduce their HbA2. Once their anemia is corrected, HbA2 might increase, and then beta thalassemia minor would be diagnosed.
So I think in case of severe anemia, I think we should repeat the HB electrophoresis after correction of anemia.
Exactly. Yes, that would prevent accidental missing of low
Beta
thalassemia minor. Yes. Sony sir's comments, sir, any comments from you?
One important comment, by my experience, because
Yes,
as
sir.
we discuss dose dilution, right? So what I do, I am using FCM since its inception.
Right.
I use in a lot. So suppose I have to give 1 gram at a time. In that case, what I do, I just dilute 500 milligram in 100 ml. I give first in 7-8 minutes, right? Yeah, maximum 10 minutes.
Right.
And again 100 ml and 500 milligram.
Right.
So problem of diluted iron for a longer time is not there. If I dilute it 250, then I will give it in 30 minutes. But 10 minutes, again 10 minutes. This is my usual practice for the patient to whom I want to give 1 gram.
Right. So it's a useful practical tip, because that is how we would be avoiding exposing that dilute preparation for long to environment.
Long time, exactly.
And apart from that, in my practice, apart from iron deficiency anemia, the second commonest cause of anemia which I see is megaloblastic, although megaloblastic is not very common in pregnancy. Third is autoimmune hemolytic anemia, and very rarely then there are rare causes like pure red cell aplasia and PNH, but these are rare. Probably in busy hematology practice, we would see 2-3 such patients every 6 months, but they need a lot of testing, sometimes bone marrow test. But yes, iron deficiency anemia still remain the commonest cause of anemia in pregnancy.
And one more thing, routinely I give, when I give IV FCM, after that I give some intramuscular pricks of folic acid and B12 to patient that just they take 3-4 pricks in a week time or 10 days. Because there are multiple deficiencies in our patients.
Yes, that is true.
So with iron, I give this B12 and folic acid also.
Any other comments from any expert panelist? So I think Nakulji, we are done for the day. You are not audible. You will have to unmute yourself.
Nakulji, you are, please unmute.
One of the important point is some of the patients are anemic, that is below 10 gram HB, and routinely we are also doing urine routine micro in all patients. And if patient is having chronic UTI also, they may have low hemoglobin levels because of chronic infection also. So in that patients, ideally, we should not directly jump to the iron replacement. Rather, we should treat the infection first and then I think retest that patient after a few days.
That is true. Right.
Doctor, one question from my side. That is how CBC report is important to evaluate anemia and which parameters we need to more focused on.
So see, CBC is very essential when it comes to diagnosing anemia, correctly diagnosing anemia. And there are a lot of indices in CBC which are mentioned. But there are 3-4 indices like mean corpuscular volume, MCV, red cell distribution width, then reticulocyte count. And of course, clinical history and background is very important. With that, just a careful look at CBC would, in almost 90% of the patients, you are sure of the diagnosis once you see patient and just look at CBC.
And what about the unexplained anemia?
Now, unexplained anemia, again, clinical. When we see patient, there is something in our mind that what can be the cause of anemia, what can be the probable cause of anemia.
Absolutely.
And then the investigations are advised in such a way that we can reach to the diagnosis. There are many causes of unexplained anemia, but if we restrict ourselves to pregnancy, it has to be iron deficiency, megaloblastic, thalassemia, sickle cell disease, and then rare causes.
Unexplained anemia is a terminology like unexplained infertility.
Right, sir. So it's a Pandora's box.
Yeah, exactly.
I think there is at least one point should be asked. Is there any importance of reticulocyte count? At least one take-home message from our obstetrician friends. Then how would you give importance to this reticulocyte count in our day-to-day practice?
I think a high retic count would always indicate an indicator towards hemolysis. If I remember my hematology from my second year, right?
So I think if the reticulocyte count is more, than what other tests should be advised, Dr. Vinay?
So, sir, if reticulocyte, now if we look into the clinical settings where reticulocyte count would be high in pregnancy, now that high should not be 2.53 because these can be some lab variation. But if reticulocyte coming, if it is coming to 7%, 8%, 9%, if patient is icteric, if indirect bilirubin is high, immediately we would look into possibilities which are pertinent to pregnancy. First is autoimmune hemolytic anemia, and second is microangiopathic hemolytic anemia, because then this spectrum of MAHA, preeclampsia, TTP, and eclampsia, there is a big spectrum. And when I see smear of pregnant ladies, if the reticulocyte count is high, if there are features of hemolysis, it has to be taken very seriously, because it can be as simple as autoimmune hemolytic anemia, easily treated with steroids, and it can be as complicated as patient have developing HUS, HELP, TTP, and eclampsia, because it's a spectrum.
In some of the part of our Gujarat, there is a more incidence of G6PD deficiency. Is there any test to identify that women of?
In females as such, because it is X-linked G6PD, we don't find it quite often. But then if you are strongly suspecting G6PD has to be done. That too, not a screening test, but quantitative G6PD.
Okay.
Yeah.
Thank you.
Yes, sir. Means we are really thankful for giving this opportunity to host this scientific webinar. You started from scratching, means like basics of anemia, then what is the role of Fcm in IDA, and definitely be a partner for this wonderful academic educational initiative. Definitely, I would like to thanks Dr. Vinay, Dr. Ritu, and Dr. Soni, and I most thanks to Mr. Samir for arranging everything.
Thank you.
Thank you,
Thank
sir.
you so much. Yeah.
Excellent presentation, Dr. Vinay. Thank you so
Yeah.
much.
Thank you so much. Thank you so much.
Wonderful
Thank you.
presentation, Dr. Vinay. And thank you all panelists, Dr. Ritu, Dr. Jignesh, and Dr. Soni, sir, for sharing your views and experiences. Thank you so much.
We
Thank
can
you,
thank
thank you so
MCure for bringing us all together.
Right.
Yeah.
Thank you so much.
Everyone
Thank
from
you,
different
everyone.
city. Thank you.
Yes.
Thank you. Thank you.
Thank you.
Thank you, everyone.
Yeah.
Yes, Ankit, you can stop recording.